Hello, everyone, and welcome to today's CalMap webinar on traumatic stress in children, how to manage in primary care settings. Very glad that you're here today. My name is Joanne Jung. I'm a general pediatrician. I help to organize a lot of these CalMap events here. Let's go on to the next slide. Just a few quick housekeeping items and reminders before we actually get started. Reminder that any time that you have a question about one of your patients with mental health concerns, please do call us. Many of our speakers are also consultants on this call line, and we are available 8:30 to 4:30, Monday through Friday. You can either place a consult online or call that 800 number that you see on the slide here. We also offer care coordination consultations as well. So in addition to being able to speak with our psychiatrists and with our psychologists, you can also speak with care coordinators and social workers about resources in your area that might be helpful for your patients. So please do give us a call. Next slide, please. Here is a quick sneak peek into some of our upcoming events. Our next webinar will really talk about trauma-informed approaches to youth self-injury. It should be really good. In addition, we have all these Project Echo series available at different times, depending on your interests and on your schedule. We will be hearing again from Joe on trauma PTSD at our next Project Echo for PCPs. It's part of our advanced series. We also have an Echo series for our school-based audiences, as well as an Echo focusing more on therapeutic communication skills. So if you want more information about what's in each of these offerings, just please scan that QR code for more information. You can also see what's on deck in these different series. Next slide, please. Quick look at our disclosures. We don't have any relevant financial conflicts of interest. Here's a quick word on some of our funders, both from the federal government as well as our state government as well. And with that, I would like to introduce our speaker for today. Dr. Josiah Cox is a child and adolescent psychiatrist in the Division of Mental Health and Child Development at UCSF Benioff Children's Hospital, Oakland, and the Division of Child and Adolescent Psychiatry at the UCSF Department of Psychiatry and Behavioral Sciences. He provides consultation for CalMap and clinical care in outpatient psychiatry clinics at UCSF Benioff Children's Hospital, Oakland. Dr. Cox recently completed training in pediatrics, psychiatry, and child and adolescent psychiatry at Tulane University in New Orleans. He completed medical school and the physician scientist training program at the University of Kansas School of Medicine. His primary interests are in integrating behavioral health and primary care pediatrics and early childhood trauma. With that, just a quick reminder that if you have any questions for our speaker, please type them into the Q&A portion. We will be reserving the last 15 minutes for the Q&A portion of this talk. And with that, I'll hand the virtual mic over to Dr. Joe Cox.
Thanks, Joanne. And it's so great to be here. And thank you all so much for taking your time and the participation is all very welcome. And I'm really excited to talk to you all about this topic. And it's a big one. It's one that can definitely take up more than an hour, and it can be overwhelming. I know, for me, it's overwhelming sometimes to take care of patients that come in and see me, and I'm sure and certain that it's the same case in primary care as well. So the goal, the objectives for this is really do kind of an overview of the topic. So, just so that we know about what the core features are, what to look for, and then how do we manage to give a roadmap or kind of a clinical pathway, a model of how to manage it in primary care, so that you know where to start, what to do next, what to do after that. So here's our more specific learning objectives. Like I said, talk about what is child traumatic stress, learn about how to prevent it. Hopefully first, you all are primary care providers. Prevention is the first step that we want to hopefully do. And then for those that we don't prevent, identifying it in the primary care setting. How do we do that? And then once we've identified it, how do we manage it in the primary care setting? So really trying very hard to give you all the information about this topic, but in a way that is helpful for you in your primary care clinics. And I just want to acknowledge these sources of other information that I've used to create this presentation. This is an area of subspecialization of mine, but I am not I have the training in pediatrics, but I'm not a primary care provider. I'm not brave enough or smart enough, I don't think. So, but so I've taken a lot of information from people who are and been given a lot of helpful feedback. A lot of the model that I'm going to be showing you all is adapted from the child traumatic stress care process model developed by Brooks Keeshan and his colleagues at the Utah Pediatric Department of Pediatrics. And AAP has a lot of really helpful resources, the Council on Child Abuse and Neglect, that I point to here as well, and as well as the National Child Traumatic Stress Network as well. So we'll come back to more resources at the end, but just want to, acknowledge where a lot of this comes from. So starting with what is childhood traumatic stress? So what are its core features? One is that it's very, very common. Up to 80% of kids will have at least one traumatic experience, and we know that it's not equally spread. So minoritized and young children are impacted most in terms of rates and prevalence. And thankfully, not all of those children who have a traumatic experiences go on to develop PTSD, but a significant portion of kids do. And that leads to the huge health impact, mental health impact, physical impact. We know that from the ACEs studies, and cost as well. The other important thing to note is that, okay, so it's really common. Are we seeing it as much as is it something we're picking up? I think we're not. And I think that's because it's often underdiagnosed or misdiagnosed. And we'll talk about why that is. And then hopefully, on a hopeful note, early diagnosis and intervention can be life-saving, really, can have a huge impact. So there's effective treatments out there for these kids that it's happening to. We have to identify them and we have to connect them with that. So that's a little bit of background about traumatic stress. So childhood traumatic stress. And now, just to define for the purposes of this talk, what is a traumatic event? I think the term trauma has been broadening, but for this talk specifically, and in psychiatry, a lot of times what we're referring to is an event that causes or threatens significant harm and to the person or their witness that to another person. So things like child maltreatment, child neglect and abuse, witnessing family or being a victim of family violence or community violence, automobile and other accidents or injuries, life-threatening medical diagnoses, natural disasters, which we're seeing more and more of in our world, war and terrorism. These are all things that can be classified as a traumatic event. And traumatic stress is what happens afterwards. And that is, intense emotional and physiologic distress. We're not going to go into all the underlying, neurochemical pathways and things like that. I don't think that is as important, just knowing that it's intense emotional and physiological distress, and that then can cause significant disruption in child development and have profound long-term consequences. And, we try our best in psychiatry to group symptoms into diagnoses just so that we can communicate with each other and communicate with our patients and families, and we can design treatments that fit to those grouping of symptoms. But there isn't really clear lines in between some of these things. And I think being able to make a diagnosis of PTSD as a primary care provider isn't as important. I think it's more important just to pick up on what are the symptoms of traumatic stress so that you can tailor your recommendations and treatment towards that. And the core symptoms are intrusive thoughts. So these can be things like flashbacks and nightmares. But in younger kids, oftentimes it comes out in things like traumatic play. So they seem stuck on playing out certain scenarios in their free play. That's the way it can look like. Avoidance is a really common symptom. So afraid of being around or even talking about things that remind them of the traumatic experience. And that's, like I said, that's a very common symptom. So example would be like, I got in a car accident and now, really getting really upset when I'm in the parking lot or when I'm trying, when I need to get in the car. Hyperarousal is another really common symptom. And that just generally can refer to, it can be present as general irritability or anger, sleep difficulty, so difficulty falling asleep, exaggerated startle response, a lot of different ways. And then finally, negative mood or thoughts. So an example of that is like something bad happened to me, so therefore I must be bad. Or another example is I got in a car accident, so all cars are dangerous. These are negative thoughts, just generalizing something from something scary that happened to in a more general way in their life. And so those are, when you have all four of those, we call it PTSD. When you have, a couple of those or one, or two or three of those, oftentimes we're calling it something like adjustment disorder is often a term we'll use or you'll see. When you have all four, but the symptoms have not lasted more than 30 days, we call it acute stress disorder, but it's essentially the same, just hasn't lasted as long. And we know that not everyone who develops these symptoms immediately after a traumatic experience, as I showed earlier, will go on to develop PTSD. And then just because you see these, because you'll see these terms used sometimes like toxic stress and complex trauma, these aren't very well defined in psychiatry, but typically refer to strong or frequent prolonged adversity. And those are the symptoms of traumatic stress, but they're not going to come out and tell you about those symptoms. So oftentimes what we're seeing is someone who seems like they're depressed or anxious, or they have a lot of behavior concerns, or then now it's, down the line, they're, developing substance use disorders. These are all things that can be presentations of traumatic stress, but they can also be comorbid with things like PTSD and other traumatic stress disorders. So it's just really tough, and that's why it goes back to it can be easily missed, because oftentimes you're seeing a kid who's super anxious or super depressed, and maybe we don't ask about traumatic experiences, and so we think maybe that's what it is, and maybe that is what it is, but it's also we may also be missing the component that's due to a traumatic experience. And when we miss that part of it, and we trying to treat the symptoms as we typically would, without the traumatic experience, it can lead to, suboptimal outcomes for sure. So, all right, so that's kind of setting the stage. This is the problem, and this is the need here. And now how do we address it? So again, and trying to focus on in the primary care setting. So first off, prevention. You all primary care providers, prevention is what you're really best at and really good at. So you all are probably doing a lot of this already, but just to give an overview of the recommended steps for preventing traumatic stress. And that is, it's really important to screen. The first step is really important to screen for risk factors. We know that there's certain risk factors that are very commonly associated with kids who are experiencing a lot of traumatic experiences. And those are things like parental stress, parental substance use, parental mental illness, exposure to intimate partner violence, housing instability. And so those are all things that often show up in standard, social determinants of health questionnaires. And so if we're picking up on those things and we're intervening to address them as we pick up on them, that's going to be helping prevent further traumatic experiences for the kids we're seeing. I really like this SEEK questionnaire. It stands for Safe Environment for Every Kid. It's one page, and there's an example here that asks, some things are not specifically, risk factors for traumatic stress. It's not designed to be just that, but it has a lot of the risk factors. And their website, which I'll link to later, has, a lot of really helpful handouts for families that you can use whenever there is a certain positive response. But the steps are, you screen for the risk factors, you acknowledge them, you can do this, have them fill it out at well child visits, in the waiting room, and then take a quick look at it, acknowledge any positive responses, and bring it up and ask them about the need and if they desire assistance. And then if they do, providing relevant information and support for them in that need. And it has, again, this has a huge impact on preventing traumatic stress from happening. Okay, so we've done what we can to limit or intervene with the risks at risk stage. And now for those kids who even with that prevention strategy go on to have traumatic experiences, what do we do next? And first, we have to identify them, right? Before we can help them, we have to pick up on them. And I think this is actually really the crucial step because, as I said earlier, so many of these kids are getting missed. It's happening a lot more common than we realize. And so some of the theory behind screening, one, there's some back and forth and it's controversial. Most recommendations are not that it's done universally as we're moving towards with universal screening for depression in adolescents, which is recommended. But screening for trauma isn't typically recommended to be done universally unless you're working in certain populations. So if you're working with populations that are really high risk, or if in kids who are in specific target groups, you can implement sort of quasi-universal screening with those groups. So these are things like people who are in the foster care, kids who are in foster care, kids who are refugees, kids who have housing instability. There's certain groups of kids where we want to be doing this with more universally because it's so common. And then it's the other side of it is also to do it anytime we have a behavioral health visit. So anytime someone comes in with a behavioral health complaint, just go ahead and screen for trauma because it's oftentimes it's a part of that. So so that's kind of when and why we're doing it, and that the idea is to catch kids so that might benefit from evidence-based treatment. And as we'll talk about, like some kids, and we said a little bit earlier, some kids experience trauma and then don't go on to develop significant symptoms and so don't need treatment. But the first part, we have to identify the kids, and then we'll get to the next part, which is deciding how to help them. So this is a really helpful screen, trauma screen that was developed by the Intermountain Group, by Brooks Keeshan at the Utah Department of Pediatrics. It's adapted from the UCLA brief trauma symptom screening. That's what part of it is, that these 12 questions here are basically asking about symptoms of traumatic stress, the ones that we pointed out earlier. The first two questions are asking about traumatic experiences. So this is where this is the first part. Like if they answer no to recent and remote traumatic experiences, they don't need to go on and fill out the symptom questionnaire. But the first part is picking up on kids who've had traumatic experiences. And then we'll get into how the symptom score can be helpful later. But the final step down at the bottom is a question taken from the PHQ adolescent version, which is asking about suicidality, which we'll get to again in a minute. This is available as a caregiver report for kids aged 6 to 10. It's been validated in that group. There's a self-report version for kids age 11 to 18, and it's available in multiple languages. So this is really for kids who are over 6. For kids who are under 6 or 0 to 5, it's really tough to pick up on traumatic symptoms in this age group because it just can look like so many different things, and it can just be harder to tease apart. So in the younger kids, we're using the SEEK or another social determinants of health that asks about common traumatic experiences like experiencing physical abuse or witnessing family violence. Okay, so we've screened, and now what do we do? Someone says yes, what do we do? So these are the simple steps, and we'll talk about what to do for each one. So first off, of course, we have to think about, does this need to be reported? And you might need to gather a little bit more information, ask additional questions depending on how they disclose it. And then once you have the information and you suspect that this warrants reporting to Child Protective Services, I put a link here to the Child Protective Service County Reporting Hotline directory. Um, the recommendation is that you call the county hotline of the location where you believe that the abuse occurred. So you can find that there and call and report. If you're not sure, one of the recommendations is to consider contacting a child advocacy center in your community. There's a directory here. These are experts that see the kids that are then under investigation and with CPS, and they can provide some guidance on whether it should be reported or not if you're not sure. Okay, so you've does it need to be reported? If it does, you've reported it. And now the next second important question is there any suicidality or worrying, thinking about safety? So like as I said before, the last question on the PTSST asks about suicidal ideation in the last 2 weeks. You may also be using another suicide screening tool. As I said, a lot of folks, and hopefully we're all moving towards universal screening for depression and with the PHQ-9. And so that also has a suicide questionnaire on there as well. There are other suicide screening tools that are also recommended. Whatever you're using, hopefully we're using something and we're asking the question. So you ask the question, and if positive, of course, we have to address that. And the way to do that is assess for suicide risk. And there's some really great tools for that. There's the Columbia Suicide Severity Rating Scale, which is just a really brief safety assessment. And I'll look at it at the next page. It breaks it down to risk level, low, medium, and high, and then that determines your next steps. So here is an example. Here's the Columbia Suicide Severity Rating Scale. And the first two questions are asking about suicidality, whether passive or active. If they answer no, then you can stop, as I said before. And that would contradict if they had already said yes on another form, but so you could clarify that. But if they say yes, but they answer no on the other questions, then that indicates low risk. And low risk, basically, the situation is passive. The kid is having passive or non-specific thoughts of suicide. And the recommendations what to do when that happens is to place a mental health referral, provide crisis numbers and resources, and follow up on the referral at the next visit, which is recommended to be within 2 to 4 weeks. If they answered yes on question 3, or question 6, but no on the other questions, that indicates medium risk. So where medium risk, that's basically the situation is there's suicidal ideation with a method, but not maybe a specific plan and no intent. And so this is the trickier one to know what to do. You may have to ask then about, or what you should do after that if they're in the medium risk is do a suicide safety assessment and create a safety plan. This just basically gathers information about risk factors and protective factors, and using your clinical judgment. If you feel like this is a family that has a lot of protective factors, has close follow-up within 72 hours, then you may decide to send them home and to follow up closely. If they don't, this may be a kid that you want to send for urgent psychiatric evaluation. And the high risk group, if they answer yes, that means in any of these questions, they have suicidal ideation with intent, with or without a plan. And that indicates urgent psychiatric referral, and then following up with the family on that afterwards. So we have there's a link here to the CalMAP suicide and safety clinical pathway. This goes a lot more detail on this topic. And I know there's been other webinars on this topic, so I won't go into too much detail, any further detail on this, but just know the important part is to address suicidality when it comes up. Okay, so you've asked about trauma. They said yes, either it's reportable or it's not reportable. They either have suicidality or they don't. And now you're at the final step, which is, what do you do next in terms of addressing the traumatic stress? So for this, we want to use the tool, the PTSD, to help us stratify the kids, to stratify our treatment. So assigning them to a risk group, kind of like we were doing with the Columbia suicide screen. Do they have mild symptoms, moderate symptoms, or high risk symptoms? And depending on their level of symptoms, that will help determine what we want to recommend next. And then along with their symptom severity, you also want to ask about functional impairment. You can ask one simple question: how are these symptoms impacting their life? Thinking about social domains, at home, academically, their health. And so here's the clinical pathway. So as we said, start at the top. Do they have a trauma exposure? If yes, first question is, does it need to be reported? If yes, you call the county CPS 24-hour hotline. If no, ask the question, suicidality. Do they have suicidality? If yes, complete a suicide risk assessment using the Columbia Suicide Severity Rating Scale and follow the suicide clinical pathway. If no, so they've had a trauma exposure, they do not report it, there's no suicidality, then you move on to assigning a risk level or stratifying treatment. So if someone has a risk score, so low or mild symptoms on the screening questionnaire, then you go over here. If they have moderate symptoms, they're mostly in the middle, then you go here. If a lot of the answers over on the right, much or most of the time, then they have severe symptoms and you go over here. So for mild symptoms, actually for every group, you want to be providing psychoeducation about trauma, provide some anticipatory guidance, like information about what can happen next, and then just provide information about some emotion coping skills. And so I imagine this being done mostly through handouts or through directing families to appropriate resources, because there's a lot of really helpful videos out there about belly breathing and mindfulness activities, things that can be really helpful. And you don't have to reinvent the wheel. And I know we don't have a ton of time. So if you have some stuff prepared, you provide it to the family, they take that home and they follow up. So, follow-up can be within 2 to 4 weeks, hopefully, and you repeat the screening questionnaire at that time, making sure the symptoms are either decreasing or staying mild. And then you can follow up again, repeating it every couple months until the symptoms resolve, and or you have to move on to the next level. So for moderate symptoms, for this category, either they have mild symptoms and functional impairment. So if it could have mild symptoms, but it's really impacting their life, you may want to consider moving over to this category. But if they have moderate symptoms, regardless of functional impairment, you want to consider referring to mental health therapy. And this could be, sort of non-specific therapy, not necessarily needing to be evidence-based. It may be sufficient just to have some kind of emotional support, or someone can help them process, and talk through what's happened. You again want to keep following up and repeating the screening questionnaire to see if they're moving one direction or another. And for kids who have significant functional impairment and moderate symptoms, or have severe symptoms alone, you want to consider at that time referral to specialized evidence-based therapy for trauma, and then close follow-up until they're connected to that referral. So and we'll talk about what are the evidence-based treatments here in a minute, but some quick caveats to that clinical pathway. I think it's useful and can be used most of the time, but there are some exceptions. So one is for younger kids. As I said earlier, it's really difficult to make a diagnosis of trauma. I think in young kids who have mental health or behavioral health symptoms, the vast majority of them are going to be either trauma or neurodevelopmental. And so it's just really tough to tell. It's really tough to tease apart. So you may want to consider sort of a binary approach for younger kids. If they have a traumatic experience and any symptoms, it's probably best to go ahead and make a mental health referral, so that an experienced mental health clinician can help figure out what those symptoms are due to. And then using your clinical judgment, consider things like, what is the type of trauma? and what are the nature of the symptoms. So intrusive symptoms in particular usually need therapy to help resolve. If it's a, particularly, challenging trauma, you may want to refer to whether or not they have symptoms or not. So you can deviate from that model is basically what I'm saying. And you just take into account some of the barriers, the type of trauma, protective factors. Is there parental attunement or capacity to support? I mean, that's an enormous factor. If you think it's a family that has a lot of stress, the parents are having a hard time. Maybe the parents are the ones that are victims of the trauma. And so in those cases, you kind of go off track and follow your gut and consider making a referral. Okay, and so now like I said, you've gotten to the bottom. They've mild, moderate, or severe symptoms. And so I said, part of it is what you're doing with any of those groups is providing psychoeducation. And that's really talking about trauma, and how we talk about it has a huge impact on how it's received. It's modeling it for the parents so that they can use those same skills with their kids. There's a lot of helpful things on our website on how to help parents talk to kids about trauma, how to support kids who have had traumatic experiences. And here's some examples from that. So like affirming affirmation of trauma response. So just helping parents understand that these are things that are happening because of what happened to them, and they're in response to that, and they're really the body trying to protect the kid from something that was really scary, and just helping them understand what's happening, why it's happening, so that parents can have more empathy and provide more support for kids. The AAP has a really helpful help mnemonic that stands for HOPE. So this is like how we can talk to kids about parents and kids about any kind of mental health concern, but definitely after traumatic experiences, expressing hope. So we're going to get through this. It's going to be better. We're going to, and empathy. I know this is really hard, and using the kind of language that they're using so that, feel like they're understood and you're on their team. Loyalty, I'm with you in this. I'm gonna stay with you, or you're not alone. Partnership, we're gonna do this together. Asking about their opinion, asking about their perspective. Permission, definitely asking before we do things that are, recognizing the power differential and asking for permission before we do things that, not taking for granted, asking about their perspective. And then, coming up with a plan. And this can be helpful. Just having any kind of plan can really help people feel more hopeful. Okay, and then, as I mentioned, psychoeducation and anticipatory guidance, there's a lot of great resources already out there that we can refer to. And then hopefully this helps everyone be efficient in the primary care setting and not feel like you have to, talk through everything themselves or be an expert on these topics. But there's use the resources that are available. So a lot of this comes from the National Child Traumatic Stress Network. And they have tons and tons of other resources and in multiple languages there. But some really helpful ones that I've found one is the Understanding Child Traumatic Stress, a guide for parents. So this is a link to that. There's age-related reactions to a traumatic event. So depending on the kid's age, how do I talk to them about it? How do I respond? How can I be supportive? And then, as I said, on CalMap, there's a lot of trauma-specific anticipatory guidance there on our website. So there's a link there to that. And there's also a link to our website where there's videos on a handout on emotion coping skills. So there's links to videos about belly breathing, about mindfulness strategies, and just basic skills for coping with trauma symptoms. Okay, and then as I got to, we've provided psychoeducation and anticipatory guidance, and now in those moderate symptoms or moderate with functional impairment or severe symptoms, this is where we want to refer to evidence-based treatment. And so just so you know a little bit about what are the key components of evidence-based treatment? So in case you want to explain it to families, or in case families come to you and say, I'm not sure this therapy is working, you can ask questions to make sure that it is an appropriate type of therapy for our kids who have traumatic stress. And those components are that it's developmentally and culturally sensitive. So it should take those things into account. It's resilience based, so strengths based, and trying to promote strengths, and that's just in the kid and the family. It should be focused on overcoming avoidance of the trauma experience. So avoidance is this natural way that we try to cope with scary things, but it's when it comes to things like traumatic stress, it tends to perpetuate the symptoms. So a lot of the therapies, a big part of it is overcoming that avoidance and facing our fears in a safe way. And that really helps, decrease that fear response, that physiologic response. They should include the parent or caregiver. So if a parent's saying, I'm not sure what they're doing in therapy, I'm just taking them and dropping them off, I think that's not a good sign. And it should be, because the parents are the ones that are going to be using the strategies that they're learning from the therapists at home and continuing the work they're doing in therapy at home. And as I said before, like it should be safe. And so that, they're including a parent or caregiver, and that's only for those ones that are not involved in the traumatic experience. So, some examples of evidence-based treatments are trauma-focused CBT, child-parent psychotherapy. Parent-child interaction therapy is really more reserved for kids who are more at risk, and there are trauma-informed models, but it's also something that can be helpful. These two above have the most research about them. There's other ones as well, and the NCTSN website has reviews of all the different types of therapy if you want to learn more or learn about the evidence base for them. Okay, so now you're saying you're a child psychiatrist. Aren't you going to talk to us about medication? Is there anything we can do in terms of medication? And it's the same impulse that I have for these kids. You want to help right away. You know they experienced something horrible, and you want to do something to help. And we're medical professionals, so the first thing we think about oftentimes is medication. And so let's talk about when and how medication may be effective for kids with who've experienced trauma. So the first thing to know is that there is no evidence for first-line use of medications for kids with PTSD. And there's some times where we use medications, but there's no evidence for first-line use of medications. I think we put the first-line part there too, because sometimes what can happen is we think, well, okay, we're going to try this medication. Maybe it'll get better from this. And I'll hold off on making that mental health referral or that referral to evidence-based therapy until we see how this medication goes, because maybe it's easier, or it's just something that, is it's just more readily available. And the problem with that is that these medications typically don't work, and then it delays getting plugged into treatment that really does work, has good evidence for it. Some other important things to know about medication use and trauma. There's a lot of data out there about kids who are in the foster care system, and some of the adverse outcomes that can happen when they're treated with excessive or inappropriately treated with psychotropic medications. We know that these kids are 2 to 3 times more likely to be treated with psychotropic medications. And for a lot of them, and that may be because they have certain underlying diagnoses, but a lot of these kids, of course, are ones that have had significant traumatic experiences. And so the idea is a lot of the symptoms that they're expressing are probably related to their traumatic experiences. And as I said, in the first line, there's no evidence for first-line use of medications. So that leads to a lot of problems, a lot of side effects. Another note about kids in the foster care system: they're 4 times more likely to be prescribed a second-generation antipsychotic, which is of course very problematic. Lots of side effects with those. And it's difficult because symptoms may look very similar to other diagnoses. but the underlying mechanism of those symptoms is different, so it may not then respond to treatment. And that's how we understand it. And even kids who do meet criteria for a comorbid diagnosis, say of like ADHD or anxiety or depression, even those kids tend to be less likely to respond to medication for those comorbid conditions. So it really impacts treatment overall. It doesn't mean you can't use medications at all, but you want to be careful about how you're doing it. So there are times where it is appropriate to treat comorbid conditions. Like I said before, they are very common, and sometimes medications can be very helpful with those. In particular, I'll talk in the next slide about sleep. So that is one area where sometimes medications can be useful. So here's kind of the type of approach to medication that I take. The first phase is ensure that they're receiving evidence-based trauma therapy and you're addressing sleep. So both of those things you can do right away. And again, this is for kids who, have severe symptoms or severe functional impairment. You're trying to get them plugged in with evidence-based therapy. And at the same time, you're working on sleep because trauma, we know, significantly impacts sleep. And that has so many indirect impacts on their mood, on their emotion regulation. And so, of course, we're going to start with sleep hygiene and addressing trauma triggers at night. But there are times, even when you're doing that, or depending on the social circumstances, you can consider using medications. Starting with melatonin is great, seeing if that works. But oftentimes, I'll then move on to doing a trial of an adrenergic agent, such as clonidine or prazosin. Those have been shown to have some improvement in sleep-related problems to kids who have traumatic stress. The second phase, then, so you're doing all that, you're in therapy, or you're trying to get them in therapy, and you're addressing the sleep. After that, then you're continuing to evaluate and treat comorbid conditions. Because as I said at the beginning, you're like, could this all be related to trauma? We don't know. We're trying to get them treatment. Maybe they're getting treatment and you're addressing the sleep, but they continue to display symptoms concerning for other things like ADHD or depression disorder and anxiety disorder. And then that's when you start to consider, maybe I'm going to try to treat these things because maybe they're also there as well. So that's kind of the two-phase approach where you're trying to prevent overtreating or mistreating trauma. And the general principles are try to be conservative, try to limit complexity, discontinue stuff before adding something else. And of course, always using a shared decision-making model with the parents and the kid, getting informed consent, with an appropriate caregiver or proxy when that's indicated. Okay, so I wanted to do a case example so that we could see how this could look. So we have a 7-year-old girl that comes into our primary care clinic. We know that they're in a foster to adopt family. And the chief complaint of this visit is the kid is being angry and mean. Okay, so first off, do we want to screen this kid? I think it's a kid with significant risk factors. They were removed from their biologic family, and it's a behavioral health visit. So I think the answer is yes. And because they're 7, you want to use the caregiver PTSST form. And then, we're going to find out from that, have they experienced trauma? I think, there's someone that was removed from their home. Maybe you don't know the whole details. Maybe the foster family doesn't know the whole details. Maybe the kid doesn't want to talk about it, or you don't feel comfortable asking about it. I think there are definitely cases where you can give them a form and they can report if they know. But even if you don't know of specifics of the trauma, I think in some cases you can kind of, you can presume that this kid has had significant traumatic experiences. Okay, the next question as we go, is do you report it? I think, so in this case, no new trauma was disclosed. There was something that was remote, and of course, it was previously disclosed, and that's why they were removed from their biologic family. The next question after that is there suicidality? So in this form, the parents say no, they're not concerned about suicidal behavior. You ask the kid, do you ever wish that you weren't alive? And they say they don't answer. So you're presuming no in this case as well, but no signs point towards it being yes. So you skip the suicide risk assessment. So you've already asked about suicidality, and the next step is stratifying treatment. So what is the caregiver PTSD score? And this is what it looks like. And I put this up here because you don't really have to go through and add up all the numbers. I think you can take a glance at it and say, well, this looks like severe symptoms. All the check marks either on the threes or fours, except for one. And so this is what severe symptoms look like. And then we know because of that, what do we do when someone has severe symptoms or a lot of functional impairment? We provide psychoeducation, anticipatory guidance, motion coping skills, and refer to specialized evidence-based treatment. Okay, and so some takeaways. So hopefully the main points we want to remember from this has been a lot of information. I hope it wasn't overwhelming, but the main things we want to take away are that most children will experience a traumatic event. A minority of those will develop significant symptoms, but trauma and traumatic experience are especially common in certain populations, in minoritized populations, and kids in foster care, kids who are refugees, are homeless, or have developmental delay. It's really important that we're screening for risk factors so that we can prevent as many traumatic experiences as we can. And then it's also important that we're screening for those traumatic experiences, especially in kids who are at risk, including those with any mental health complaint. And it can be really helpful to use a rating scale, such as the PTSD that I showed here, to help us know what to do next. Because sometimes someone could have like I said, could have a traumatic experience. A minority will develop symptoms. So a lot of kids will have a traumatic experience and not need any further, significant, mental health referrals. Could just provide some psychoeducation. But it'll help you, using the clinical pathway will help you know what to do next. Here's some really helpful resources. As I mentioned, the Safe Environment for Every Kid, the Child Traumatic Stress Care Process Model that a lot of this was based on, the National Child Traumatic Stress Network, and a lot of great resources from the AAP. And here are my references, just so you know they're there and you can look to if you want to see more information. And thank you guys so much for listening and opening up for questions.
Wonderful. Thank you for that great talk. And I hope I put the right link into the chat, but we can double check that in a minute. A question did come in, and the basically has to do with how to find appropriate therapists. So especially in areas like the Central Valley, where access to therapy is very difficult, given the just overall lack of pediatric therapists, as well as the fact that many don't actually take insurance. So any tips on how to find therapists or any teletherapists that you know of?
Yeah, thank you for that. And I'm sorry for not acknowledging that, to start, because that is a reality. I mean, it's so easy to say you need this type of therapy. It's a lot harder to find it. And I know that's that's the frustrating thing is it's like, okay, I know what to do. I know that this kid needs this, but I don't know how to get them that. So first, I want to make a plug for CalMap services Joanne mentioned earlier at the very beginning. One of the services we have is care coordination. And so you may have a care coordinator in your clinic or you may not, but it can be so helpful just to have somebody who is familiar with how to navigate the system. So we have a wonderful team of care coordinators who have full-time social workers and social work interns who first will talk to you and figure out, okay, what are we looking for? Ask some questions about what type of insurance they have and help figure out if there's any kind of simple next steps that can do. But oftentimes when there's barriers or, we've already tried those first steps, they're able to reach out directly to the families and help them walk through the steps to find what they need. And that's oftentimes contacting their insurance company with them. Sometimes it's going through the school system to get some type of therapy that they can get through there. Sometimes it's, going through, other online resources. It depends on what the barriers are, but they'll work with the family to try to find it. There are on those websites I mentioned on the NCTS on the National Child Traumatic Stress Network.org. There are links to lists of providers if you're looking for types of providers that provide evidence-based trauma-focused therapy. You can put in your zip code and you can try to find providers. Also on the child parent psychotherapy um, website, there's information about providers who provide that type of therapy. It's really tough. It's really, really, really tough. So ask for help when you can, if you can get it. And just, I hope you don't feel like that's the only thing that you can do. Like so much of what you're doing already in how you're talking to families, acknowledging what they've been through, providing psychoeducation, providing some coping skills, addressing sleep, all of those things are super important and very, very therapeutic. So hopefully, I know it's really hard to find the type of therapy we need, but hopefully that's reassuring.
So we did drop a couple of those links to the NCTSN site as well as a child parent psychotherapy site. Parent-child interaction therapy also has their own website where you can look at people who have been trained in that type of therapy also, so you can look there. And definitely do call our care coordinators at CalMAP and they can help find some local resources particular for you. But given that many times, like we've tried this, we've tried going through the school for educationally related mental health services and trying to get counseling that way, sometimes not there is what particular anticipatory guidance might we be able to provide? Like as pediatricians, like brief interventions, brief tips, or clinical pearls that we can pass on to families that can help to maybe buffer some of the stress they're experiencing.
Yeah, yeah, it's a lot of times parents are asking me how do I respond, and I think it's like you just don't know because maybe your instinct is that maybe we shouldn't talk about this because it's really scary. What if it makes them more upset? I don't want them to be upset. And also sometimes the parents or the caregivers are the ones that have also experienced the trauma. You think about instances of intimate partner violence. Maybe it's just too hard for that parent to talk about or be supportive in the way that you ideally they can be. So you want to acknowledge that and just listen to what they're experiencing, what they've been through, and that is therapeutic in itself. And I think that's again the parallel process. You're modeling this behavior with the parent so that then they're going to carry that over with the kid. So the main thing is if the parent can listen to and just acknowledge whenever a kid is talking about what's happened to them or their symptoms, being empathetic and just acknowledging, yeah, that was really scary. That was really hard. That is huge and provides such a buffer for these kids that have been through scary things. So, if parents are capable or have the capacity for that, again, it depends on what's going on in their lives. But if they have capacity for that and they can do that, you can recommend that. Um, and model that for them too. So I think that's if you can only do that one thing, how to just help acknowledge the kids' symptoms and how they're feeling. It can also help put their emotions into words. So if a kid is obviously very upset or very angry, even just helping them learn how to put those into words so that they can use those words instead of the actions that they're using as they grow up, as they mature. Things like, wow, I know you're really angry right now. I know this is really hard right now. I'm with you. Also reassuring, so especially for those kids that have had scary things happen, either from, because of another caregiver or another important person in their life, the person that is still in their life and is still their caregiver, expressing, support, like, I'm going to be here with you. I'm going to keep you safe is really helpful as well for those. So it depends on the type of trauma a little bit, but in general, those are some helpful tips. And then remembering that avoidance is something that perpetuates a lot of the symptoms of trauma. So if families can help kids not do avoidance or limit avoidance, so getting back to routine, getting back to kind of how things normally are really helps kids move forward and helps reduce symptoms over time too.
Absolutely. It reminds me of it's a quote from Mr. Rogers. What's speakable is tolerable. So just being able to offer kids that space to be able to talk about like what was difficult, what they, what they're feeling, and to help give name to those feelings, as you said, it can often be very, very helpful. Great. Um, so I want to call attention here to the QR code. Go ahead and scan that or use the link in the chat to claim credit for today's session. Um, we hope to see you at our next session coming up on January 30th, and that will be on basically non-suicidal self-injury or trauma-informed approaches to addressing youth self-injury. So we hope to see you there. A big thanks to all of you for showing up. Big thanks to our speaker, Dr. Joe Cox, for our great talk today. Hope to see you next time. Take care.